Hello, everyone, and a warm welcome to today's edition of Podcast. Today is October 1st, 2024, and I'm Rifat Mandan in California. So today we are very delighted to invite back Dr. Hadas Skupsky, who has been on our platform earlier. And in fact, today she is spearheading this dermatopathology lecture series. I want to really thank Dr. Skupsky for organizing this lecture series, along with Dr. David Casarino, who already delivered 2 lectures on cutaneous lymphomas on podcast. Thanks to both of you for organizing this lecture series. And to all of you, please stay tuned for the upcoming sessions. So we are going to have a very star-studded lineup of speakers for a very educative dermatopathology lecture series. And today is the first lecture that Dr. Skupsky is taking, and she's going to talk on the histology and introduction to dermatopathology. Over to you, Dr. Skupsky. Thanks so much for joining us.
Okay, thank you so much. Thanks so much for inviting me back. It's a pleasure to be here. I'm really excited about the lineup we have for you for this DermPath series. Just really all-star DermPath lecturers ahead. So the point of today's lecture is basically an overall intro to dermatopathology, looking at normal skin, some basic terms, and how to approach dermatopathology slide. And with that, I'm just going to shut off my video before I start the lecture. All right. So starting here with the outline, today we're going to cover the normal histology of the skin, hair, and nail apparatus. I want a little caveat here where I'm going to dwell a little bit on the hair. The reason being is that, when I learned DermPath as a dermatology resident, because I did dermatology and then dermatopathology, I felt like I kind of got thrown into the fire a little bit trying to analyze alopecia biopsies, hair loss biopsies, without really ever getting a solid understanding of the hair apparatus, the hair cycling, and what exactly I'm looking at under the slide. So I'm really going to go into some detail there on the hair to prepare you for the alopecia lecture ahead. And then a quick look at the nail apparatus. Then in the second portion of the class, we'll talk about just a general approach to dermatopathology diagnosis, some terms and conditions, and important differentials. For this lecture, I borrowed lots of images from Dr. Elston and Dr. Farringer's book on dermatopathology. This is, I think, my all-time favorite DermPath introductory level textbook. I think this is an amazing primer for anyone studying dermatopathology that wants to get a really nice, well-rounded knowledge for things like the derm boards, the path boards. It'll cover all the highly tested entities, amazing pictures, and really nice, succinct descriptions. McKee's Pathology of the Skin. So this is more of a reference. It's a chunky 2-volume series, as well as Bologna, which is kind of the Derm Bible, another kind of two-book, huge mega volume. But these are great references with amazing photos for both dermatopathology, clinical pathologic correlation when we're talking about McKee's, and dermatology all around for Bologna. So starting with our schematic representation through the epidermis, the epidermal layers from the surface are the stratum corneum, the granular layer, the stratum spinosum, the basal layer. Normally, differentiated keratinocytes require about 2 weeks to exit the nucleated compartment and go into the cornified layer, the anucleate layer, and then they spend an additional 2 weeks approximately in the cornified layer before they are shed. The basement membrane zone represents the junction between the epidermis and the dermis. And this in and of itself is a quite complex structure, as you'll kind of learn more in detail when you get to the immunobullous disorders, where this is a target of some disease states. In addition to keratinocytes in the epidermis, we also have some other cell populations. So melanocytes are going to be the cells that are producing melanin and supplying melanin to the surrounding keratinocytes through melanosomes. Normally, they're about every 10th layer, every 10th cell in the basal layer. But in certain anatomic locations, like in sun-damaged areas of the face, they are increased in number. Then you also have Langerhans cells, which are our antigen-presenting cells. Now, wouldn't it be nice if when we look at a slide under the microscope, we have all the cells kind of popping out at us and looking different, just like this? In reality, what we see when we're looking under the scope, of course, with an H&E stain, is seen here with our different layers. And so the Langerhans cells are essentially invisible. You don't see them on the routine stain sections. And with melanocytes as well, you don't really, they don't pop out at you. You don't necessarily see their dendritic processes sharing with the keratinocytes. Instead, you see a very subtle difference for melanocytes compared to surrounding cells. And I often get asked, when I'm teaching residents, how do you tell which is a melanocyte when you're looking, especially when we're trying to evaluate pigmented lesions, lentigines, and trying to see what is exactly the cellular density of our melanocytes? So one thing that I like to point out that's really helpful is that oftentimes we get a little bit of an artifact, kind of a vacuole around the nucleus in a keratinocyte. But around that vacuole, you have the keratinocyte cytoplasm. And then beyond that, you have desmosomal connections connecting those keratinocytes to each other. Whereas a melanocyte does not have those desmosomes, right? So it is not being connected to any of the surrounding cells. So in our tissue sections, the melanocytes are going to always have kind of a vacuole around them. They shrink away from the other cells. And the way to know if it's a melanocyte versus an artifactual vacuole in a keratinocyte is to say, where is the cytoplasm? The cytoplasm of a melanocyte typically kind of shrinks and kind of sticks to the nucleus. So you can kind of see that here. You get a little bit of a gray-brown cytoplasm just kind of sticking to it. And then the vacuole is around both the nucleus and that cytoplasm. That's a really nice way to kind of tell apart those subtle melanocytes. But of course, when we really need it, we have IHC for that. So we'll often throw on some melanocytic markers, Melan-A, MART, SOX, etc., to highlight those cells. Here we have the maturation, stages of maturation of basal keratinocyte to a cornified one. And my apologies, I'm just recovering from laryngitis, so I have a cough drop in place, but if I cough a little bit, please forgive me. So we have a basal layer keratinocyte that again, it takes about 2 weeks to mature up to the cornified layer. And they start off as a columnar basal cell, and then they mature to become a polygynous spinous cell, then a diamond-shaped granular cell, and lastly, a flat enucleate cornified cell. This maturation process creates a polarity to the epidermis. We know exactly which way is up or down. Even if we don't necessarily have dermis, we just have a superficial shave biopsy of epidermis, normally we can immediately tell which way is up and down. Where in pathologic situations, we can lose this polarity. So there's dysmaturation. For example, dysmaturation seen in actinic keratosis leads to jumbling of the lower portion of the epidermis. In squame, we have complete loss of polarity. In situations where we have inflammation or other trauma, injury to the skin, we'll have retention of nuclei up in the cornified layers. So we can immediately tell when there are issues with this normal skin maturation process in pathologic states. So here's an example of actinic keratosis, where instead of that beautiful organization, we're starting to have jumbling of the basilar keratinocytes. So the lower portion of the epidermis is starting to become atypical, a little bit pleomorphic, different size and shape nuclei. And in addition to that, we have overlying parakeratosis because of that dysmaturation. Notice that in an actinic keratosis, that characteristically spares our adnexal structures. So here we have a beautiful a follicle that is being spared from that atypia. On both sides, we have that dysmaturation with parakeratosis. Here is a squamous cell skin cancer, just illustrating that complete loss of polarity. So here we have so much dysmaturation that we don't even know which way is up or down anymore. With that, I'm going to move on to regional variation in skin anatomy. And I like to consider this kind of a little game, guess the site. So I'm going to present 6 different anatomic sites. And before I kind of throw on the answer, I'd like you to think really quick, where can this be coming from? And this is a game I actually play all the time. Under the microscope, I'm always looking at biopsies blinded. So I never like to have any information when I'm looking at a slide. I don't even want to know the site. I don't want to know anything about the patient or what the differential is. I want to look blinded and see what kind of clues I can glean from what I'm seeing. Um, so this is a worthwhile exercise. Here we have the first slide is a punch biopsy through the skin where we have a really, really thick dermis, kind of thick collagen bundles. Um, and this is skin of the back. So characteristically, skin of the back has a super thick dermis. So thick, in fact, that when you get a punch biopsy of the back, it can actually appear squared off instead of tapering like a normal punch does. That collagen is so thick that you get this kind of squared look to the punch. And we'll even talk about there's a differential for that when you have a squared punch later on. The second image that we have here, we see skin with lots of large hair follicles. And those hair follicles are situated deep in the subcutis. They're terminal hair follicles, meaning they have pigmented hair shafts within them and they are deeply rooted in the subcutis. So this is skin of the scalp. Next up, we have skin with this purpley hazy stuff in the upper dermis. That is solar elastosis. So actinic degeneration of elastic fibers in the upper dermis. That lets us know this is sun-damaged skin. In addition to that, we have tiny little vellus hairs and prominent sebaceous lobules. So this is skin of the face. Next up, we have skin with no cornified layer. And then the epithelium has pale glycogenated keratinocytes. Beneath that, we don't see any hairs or anything like that. Instead, we see in the dermis kind of delicate collagen with lots of dilated kind of vascularity. So this would be a mucosal site. Excuse me. Ooh, I thought I was over my laryngitis. Anyway, let me take a drink. Sorry about that. Let's continue our game. Next up is one of my favorites. Here we have compact hyperkeratosis. Beneath that, we have another layer of the skin that we didn't discuss that only, in fact, is supposed to happen in this special site. That's called the stratum lucidum, or a clear layer. Beneath that, we have our epidermis. In our dermis, again, we don't see any hair follicles. Instead, we only see sweat glands, so eccrine glands and coils. This is acral skin. So skin on the palms and soles would have this characteristic appearance. And next up, our skin has acanthosis, slight papillomatosis, this undulation up and down. And in our dermis, we see a bunch of smooth muscle bundles. Normally, we only see smooth muscle bundles associated with hair follicles, erector pili muscles in our normal sites. But in this case, we have lots of smooth muscle bundles. This is skin of the areola. Another special site that looks quite similar but has just more delicate smooth muscle bundles would be genital skin of the scrotum or labia. And you might be thinking, why should I care about special sites? So there's a few reasons you should care. First off, if you practice DermPath, knowing where the biopsy came from and making sure that what you're seeing in front of you fits can actually help you catch errors. So just this last week, I caught a mixed up specimen between two patients that was submitted. Why? Because something came in as rule out, a nevus on the neck. And I said, that's not a neck, that's a scalp. So we called the clinic and they reversed to biopsies. It happens, it's a rare thing, but it's important for you to be able to kind of catch those things. Another reason is that certain disease states in dermatology change, of course, our anatomy. And so some sites might start to look like other sites, and that's an indication of disease. For example, In lichen simplex chronicus, a condition of chronic rubbing. So when the skin is chronically rubbed anywhere on the body, you start to have changes that make it resemble acral skin. So remember with acral skin, we talked about that compact hyperkeratosis having a stratum lucidum. Normally, we don't see that anywhere else, but if the skin is rubbed, any site can start to look like acral skin. So there's something called the hairy palm sign, which is cute. That is when you see what looks like acral skin, right? But it has hair follicles. So of course, palms and soles don't have hair follicles. If you see what looks like a palm or sole on a slide, but there's a follicle, you have a diagnosis. You have a diagnosis of lichen simplex chronicus. Another example of sites starting to resemble other sites is in androgenetic alopecia. When you have a biopsy of late-stage androgenetic alopecia, you can actually have what looks like a biopsy from the face, just tiny little vellus follicles, really prominent sebaceous lobules, and even solar elastosis in advanced stages. And so you put down the slide and you're thinking, okay, I'm on the face. And then you say, and then you look at your requisition and say, oh no, wait, I'm on the scalp. You have a diagnosis. Your diagnosis is androgenetic alopecia. All right, next up we have hair anatomy. So again, I warned you I'm going to go into a bit of excruciating detail here, but hopefully you'll appreciate it when you get to your alopecia lectures, because if you can't know what you're looking at, both in vertical and cross section of scalp, understanding the hair follicle, where exactly in the follicle are you, and what stage of the hair cycle it is, you will not be able to sufficiently analyze hair alopecia biopsies. So first, hair is everywhere except our palms and soles. It's formed by the intimate association between epithelial buds and mesenchymal elements. And in the scalp, hair follicles are grouped into follicular units. So this is what the follicular units are. It's the 2 to 6 terminal hairs plus vellus hairs. Normally that ratio is about 7 to 1 terminal to vellus in a normal scalp. Then you have, of course, associated sebaceous glands and erector pili muscles. You can use a trichrome stain to really highlight those follicular units. You can see how the collagen is just kind of different as it kind of collects around each individual follicular units. So little groupings of follicles and their associated structures. As we talk about hair, we also need to distinguish terminal hairs and vellus hairs. So your terminal hairs are going to be the ones that are descending to the fat. The roots are rooted in the fat. They are pigmented. Their hair shaft diameter is greater than the thickness of their inner root sheath. I'll show you that in a moment. Vellus hairs and miniaturized hairs, that is terminal hairs that pathologically become vellus hairs, are ones that are thin, short, and non-pigmented. The hair shaft diameter is less than the thickness of the inner root sheath. Indeterminate hairs are those that are intermediate in size. The terminal follicles reach the fat and are deeply embedded within it. The vellus hairs and miniaturized follicles are located in the dermis. So note the difference between the relative size of the hair shaft and the inner root sheath in the terminal and vellus hairs. So terminal hair here, we have our hair shaft diameter larger than the diameter of our inner root sheath. And in our small vellus hair rooted in the dermis instead of in the fat and non-pigmented, we have a hair shaft diameter that is smaller than the diameter of our inner root sheath. So next up is just a vertical section view of these in real histologic section. So a terminal hair on the left, a vellus hair on the right. So again, terminal, we see it's rooted in the fat, adipose tissue around it. It is pigmented. The vellus is rooted, the bulbs are in the dermis, and they are non-pigmented. Hair follicle anatomy, the most important thing in knowing how to interpret the horizontal sections is knowing what level of the follicle you're in. So the hair follicle is anatomically and functionally divided into two distinct segments. There's an upper segment and a lower segment. The upper segment consists of the infundibulum and the isthmus and is non-cycling. It is stable. So this part does not change with the hair cycle. The lower segment is active and cyclical. So you're going to have your different phases occurring here, anagen, catagen, telogen. And then the lower segment, we have our stems and our bulbs. So starting with our lower segment, first we're going to take from the very bottom of the hair and work our way up. So the lower bulb here, we don't have the normal layers of the hair and the hair shaft yet. In the vertical and horizontal sections here, right? So vertical section, horizontal section. Note that there's a papilla, a dermal papilla in the center, which is the mesenchymal cells that actually induce the formation of the follicle around them. Then we have surrounding that the matrical cells and supramatrical cells with intracytoplasmic pigmentation from the dendritic melanocytes that surround the dermal papilla. Note the resemblance of our matrical cells to the basaloid cells of a pilomatricoma. So here we have an example of a pilomatricoma, a benign tumor of the hair matrix, and that is composed of those matrical cells of our hair bulb. Characteristically, a pilomatricoma has this transition from the blue basaloid matrical cells, has often a little transitional zone and then becomes these ghost cells where we have just a shadow of what the cells used to be. And that's our pilomatricoma arising from matrical cells. So next up, we're going to make our way to the upper bulb. In the upper bulb, this is exciting because this is where we get all of the layers of the anagen follicle that can easily be identified and is commonly tested actually as well. So this is where you have all those layers that you can point and ask, what's this, what's this, what's this? So the hair shaft, which in turn has the medulla, cortex, and cuticle, an internal root sheath with a Huxley's and Henle's layer, external root sheath, vitreous layer, and fibrous root sheath. So here is a vertical section of our hair showing those layers. You don't always see the medulla of the hair shaft, but when you do, it looks like this. Then you have your cortex of the hair shaft. Then there's two cuticles kind of touching each other. You can't really make them out apart. There's the cuticle of the hair shaft and then the cuticle of the inner root sheath. The inner root sheath is going to be composed of two layers in turn. So the Huxley's layer is on the inside and the Henle's layer is on the outside. I always remember if you had a pet hen, you'd keep it outside, right? So Henle's is on the outside. Then you have an external root sheath, or also known as the outer root sheath, which is this layer where at the suprabulbar zone and in the stem is going to be pale and glycogenated cells. The next out is the vitreous membrane, that thin pink membrane, and then an outer fibrous root sheath, kind of concentric fibroblasts outlining that follicle. Here is just a juxtaposition of a vertical section through that upper bulb compared to a horizontal section, and again seeing all the layers. So medulla in the center, the cortex of the hair shaft, the two cuticles side by side, cuticle of the hair shaft, cuticle of the inner root sheath. Our two inner root sheath layers are Huxley's and then our Henle's. And then we have our inner root sheath. I'm sorry, we have our outer root sheath. That was the inner root sheath. The outer root sheath is the pale glycogenated cells, vitreous membrane, and fibrous root sheath. All right, so we covered the upper bulb. Quickly, let's touch on the Adamson's fringe. So the Adamson's fringe is the transition from the bulb to the stem. There's loss of trichohyalin granules and nuclei in the inner root sheath, and the hair shaft at the junction of the stem above it and the bulb below it, above the level of the Adamson's fringe, the inner root sheath keratinizes completely. So here we see that transition. So inner root sheath has in our bulb, in our suprabulbar area, we just saw, has these trichohyalin granules. It's granular. Above the Adamson's fringe, where we're starting to get into our stem, there is no more nuclei in our inner root sheath. It is just nice and smooth and pink. So that's kind of how you know in cross-section if you're looking at a bulb or a stem. All right. So next up, moving on to our stem. So this is our stem in cross-section and in horizontal section. And again, no nuclei in our inner root sheath. And note the smooth lining of the inner root sheath. So our inner root sheath is really, really nice and smooth. The pale glycogenated cells of the outer root sheath in the stem area are likened to piano keys. So when we look at them, they're kind of elongated, pale cells resembling the white piano keys. Next up, moving on, is above the stem, we have the bulge. This is the area of the insertion of the erector pili muscle. And it's the transition between our stem and our upper portion, the isthmus. So here we have the transition between the lower segment, the stem, and the upper segment, the isthmus. At this site, the inner root sheath is shed, right? So we were following that inner root sheath from when it got keratinized, right, at the level of the stem. And now it is being shed right here. We see it being shed at the level of the isthmus. And above that, we have instead the tricholemmal keratinization that is characteristic of our isthmus. So that abrupt keratinization now of the outer root sheath is abruptly keratinizing to make this pink chunky keratin, which is going to let us know that we're in our isthmus. So the upper segment is, again, the isthmus and the infundibulum. We're now focusing on this area. And first, the isthmus is defined by the area between the bulge and the entrance of the sebaceous duct. The inner root sheath has desquamated completely. We just have chunky, wavy tricholemmal keratin produced by the outer root sheath, seen here in cross-section. A pilar cyst, also known as an isthmic catagen cyst, originates exactly here. So notice this chunky tricholemmal keratin, this abrupt keratinization of the outer root sheath. That is the same type of keratinization we see in a tricholemmal cyst, also known as a pilar cyst, abrupt transition from those pale glycogenated cells to bright pink chunky keratin. Here we are in our isthmus, just looking at that in both vertical and cross sections, and comparing the isthmus to our stem. So in our isthmus, we have that tricholemmal keratin, a chunky keratin, whereas below in our stem, we have smooth inner root sheath. Okay, so our inner root sheath is still present. Here, our inner root sheath is gone and instead has been replaced by tricholemmal keratin. Marching our way up to the infundibulum. So now we're at the tippy top of the follicle, almost there, guys. And so here at the infundibulum, we now have normal, basically epidermal pattern maturation. So here our keratinocytes are going to mature with a granular layer. And notice also that the transition between the isthmus and the infundibulum is not abrupt. So unlike that sudden loss of that inner root sheath and the abrupt transition from our stem to our isthmus, going from our isthmus to infundibulum, just kind of slowly we get that change. We go from tricholemmal keratinization to slowly normal epidermal type keratinization. Remember also that both of these do not change with the hair cycle. So I like to kind of test and tease my residents. I'll show them a cross-section of an infundibulum or a cross-section of an isthmus, and I'll ask them, what stage of the hair follicle are we in? And they always say anagen because they're not seeing the characteristic changes that we'll talk about of the catagen or telogen follicles. And I say, you're wrong. You can't know. We don't know what stage this hair is because we're not deep enough to tell. So you can't do your catagen telogen counts at the level of the isthmus or the infundibulum. So that brings us to our hair cycle. Our hair cycle, whether terminal or vellus, is divided into three stages. So, meaning the hair cycle happens terminal hairs, it happens to vellus hairs. We have three stages. The longest stage is anagen. Most of our hairs are in the anagen stage, about 2 to 7 years they spend in that stage. Then there's a 2 to 3 week catagen phase, followed by a very short telogen stage. So the 2 to 3 weeks for catagen, 100 days for telogen. Now, here we see the anagen stage follicle. So I'm showing both vellus and terminal hairs side by side just to make the point that both of them have an anagen stage. But of course, this is the anagen is kind of the stage that we're used to looking at the hair, that where it's nice and organized with a bulb and everything is completely orderly and healthy that we talked about when we looked at our bulb. Vellus just higher up, non-pigmented, terminal anagen in the fat, pigmented, but they both have the same kind of structural quality. As we switch from anagen to catagen, the matrix starts to disappear, the matrical cells. A thin rim of epithelial cells surrounds the papilla. The epithelium of the lower follicle undergoes disintegration by apoptosis. The vitreous layer and fibrous root sheath markedly thickened. So here I like this kind of schematic representation of the process going from an anagen hair to a catagen hair. We see this kind of funny change where stuff is kind of involuting and stuff is kind of shrinking and condensing around that follicle as it's shrinking and making its way further up into the dermis. As the epithelial column moves upwards, a collapsed fibrous root sheath is left behind. This is the so-called stela or streamer, also known as a fibrous tract remnant. So we'll talk about that in a moment. And the club hair begins to form. So the catagen hair is starting, as it's kind of degenerating, the bulb is starting to make that club hair bulb. The club hair being the telogen hair at the end of that is ready to actually be shed from the scalp. So this is what it actually looks like in the tissue. So in catagen, we are seeing that disintegration happening to the lower segment, where instead of our matrical cells being nice and blue, they're starting to have this degenerative change, lots of apoptosis all over the place, dyskeratotic cells. And then this really bright pink orange keratinization towards the hair shaft as it's forming that, that flamethrower-like appearance that will be the end stage of this, the telogen hair that is ready to be shed. Here we see the same thing in cross-section, and we have side by side actually a catagen hair and an anagen follicle, both at the level of the stem, right? So here we have a smooth inner root sheath that is keratinized, so I know that I'm at the stem. And here is a level of the same level follicle, but in catagen. Now we have this bright orange keratinization, lots of dyskeratotic cells, so catagen versus anagen stem. Note also that there's a secondary hair germal, a little mesenchymal papilla starting to develop beneath that catagen hair. That's important in terms of our hair cycling. All right, so as the catagen hair kind of involutes and moves its way upward, we get this condensation of the vitreous, thickening and condensation of the vitreous membrane and of the outer fibrous membrane. It all kind of collapses as the hair makes its way up, leaving this fibrous streamer that will eventually serve as the elevator for the new anagen hair that forms to climb back down to root itself in the fat. Here is catagen and transitioning to telogen. So schematically, seeing the two, notice there's not a huge difference just looking at them. I can't tell when I'm looking at a hair necessarily if it's catagen or if it's late catagen or telogen. The transition is not abrupt. So really, when I do my catagen telogen counts, I lump them together. I say what's anagen versus total catagen and telogen hairs. Don't worry about really differentiating the two. Just understand that telogen is the end stage of the catagen process where now the hair is ready to be shed. When we are looking at the telogen hair, in cross-section, we have a below the telogen hair that's forming. I want to point out that there is this star-shaped, kind of asterisk-shaped structure that's dermal mesenchymal cells. This is the secondary hair germ that is going to induce formation of the new anagen hair that's going to take the place of the shedding hair and take root here. Beneath that is our fibrous tract remnant. And it's important because you're going to see all of these in cross sections as you're looking at alopecia biopsies. And when they're present in abnormal amounts or in abnormal distributions or abnormal ratios, it's going to help us make diagnoses. So just recognize, know what you're looking at. This is a cross section of a fibrous tract remnant. This is a cross section of the secondary hair germ indicative of the presence of a telogen hair right above it. So looking at the actual telogen hair, so the very end stage, right, when you're done with your catagen and your hair is now in the telogen stage where this is ready to shed. If somebody kind of yanks it, it'll come right out. It's the so-called flamethrower appearance. So now we've basically completely had a ton of dyskeratosis, pycnotic change of the surrounding matrical cells, giving rise to this bright pink flamethrower keratinization appearance. And then beneath that is our fibrous tract remnant. So this is what the fibrous tract remnant looks like in vertical sections. So it really looks like that, squiggly remnant of those membranes that used to surround that anagen follicle. And so just, I like this schematic to illustrate that, because the hair cycle, it's a cycle, right? It's not a linear process. And it actually took me a while to grasp this. As we're losing our telogen hair, our new anagen hair is actually forming right beneath that. So stem cells from the bulge area migrate to form the secondary hair germ that we talked about, that asterisk-like structure. They wrap around the fibrous papilla to form a new anagen hair, shown here developing in hot pink. They'll induce the epithelial cells to develop around that secondary hair germ to form the new anagen follicle, the new anagen bulb. And then, so the hot pink anagen follicle starts to make its way down while the blue-green telogen hair is being shed here. The new anagen hair then travels down that fibrous root sheath, stella, stream, or whatever you want to call it. It's serving as an elevator for that new hair to make its way down into the dermis. So you might be feeling like this right now. Oh my God, that was a lot about hair. But I'm hoping that when you come back to this, as you get ready for your alopecia lectures, it will be quite helpful for you. And I will only briefly discuss the nail apparatus. So when we look at our nail apparatus here, we have the nail, the nail plate is produced by the nail matrix, which is here. There is a proximal matrix and a distal matrix. The area overlying the matrix is what we see as the lunula, clinically, that kind of white, moon-shaped structure at the beginning of our nail. And then beyond the nail matrix, the nail plate is adherent to the nail bed. And as the nail plate kind of starts to hang off of our nail, beneath that is the hyponychium, the skin beneath the nail plate. From a pathology standpoint, I borrowed this photo from Sylvia Gottesman. She posts amazing photos on Twitter, and I just love following her images. She's actually going to help. She's actually going to be a speaker in our series later on. She's going to be teaching us about our granulomatous and histiocytic disorders. So stay tuned. But Sylvia posted this beautiful labeled image showing here the eponychium, also known as the proximal nail fold, going into the cuticle. We all know our cuticle that kind of goes right on top of our nail, the nail plate, the ventral portion of the proximal nail fold. Here is our proximal nail matrix, our distal nail matrix. Ignore the neoplasm that's developing here. That's why this was biopsied. But I think this is just a lovely photo, just illustrating that and showing it kind of side by side with the schematic. All right, so we've covered our normal histology of hair, skin, and nails. Next, I would just like to touch on an approach to diagnosis in dermatopathology. So the most important thing I would say when you're first starting to learn derm path especially is taking a top-down approach. I always encourage my residents to do this because when you first look at a slide, it might be a little bit overwhelming. Where do you start? What to look at? A lot of times people default to immediately trying to look for the pathology and to describe it. Don't do that. Take a layered approach. The nice thing about our skin is that it's in beautifully arranged layers. And so you want to kind of go through each and try to describe what you're seeing. It'll help you, A, get comfortable with the terms, and B, buy you some time. If you're at a multi-headed scope session, you can kind of talk your way through all the layers. And it'll also make sure that you do not miss any subtle clues, because you'd be amazed at how many subtle clues you can find in dermatopathology that'll help guide you to diagnosis. So start with the epidermis and then even go through the layers of the epidermis. Then make your way down to the DEJ. Is there any abnormality there? Then the dermis. Is there any abnormality to my dermal components, to my collagen, to my ground substance, to my vessels, to my, nerves, anything that's in the dermis? Do I see anything abnormal there? And then make your way down. Oh, sorry, that's a type of subcutis. So, of course, our fat, if we see any sort of paniculitis or changes to the septa of the fat. Next, I want to introduce the concept of inflammatory reaction patterns. So Bernie Ackerman was the first, I believe, to really stress the importance of and describe inflammatory reaction patterns in the skin. So he wrote this seminal book, and Histology, Diagnosis of Inflammatory Diseases, an algorithmic method based on pattern analysis. And I think pretty much every derm path out there has a version of this on their shelf somewhere. So Bernie Ackerman was a founding father of dermatopathology, and he kind of showed if you can describe the pattern of inflammation at scanning magnification, you do not need to go close up to find these patterns. Just look at scanning magnification. Where is our inflammation or our change? And then describe that pattern can help us kind of hone in on the correct differential, or at least the correct chapter of the textbook to look at to see what could this disease be. Major tissue reaction patterns have since been kind of elaborated and expanded and so forth, but the major ones are listed here. So I'm not going to go through these in any detail because you're going to have actually in the upcoming series, we're starting with the inflammatory portion. So you're going to have lectures discussing each of these reaction patterns and entities on those differentials in detail. But you're going to learn about lichenoid process, psoriasiform reaction pattern, spongiotic, vesiculobullous, granulomatous, vasculopathic. Again, these are, schematically represented here as inflammatory reaction patterns. The idea being these are things that you are looking at scanning magnification. Do not, when you're looking at derm path, do not zoom up close immediately. Do not go to high power. In fact, that should be the last thing you do when you're examining a derm path slide. First, look at your layers at low power, then look at your inflammatory reaction patterns or clues on low power. Is there anything that you can see that you can label as one of these processes? Mantra in derm path. So low power diagnosis is a high power mind. So this is not necessarily the case in other areas of pathology. As a dermatopathologist, I'm well aware of that. My, pathology trained colleagues and the path residents that I work with sometimes I think have a hard time approaching the derm path slide because they're so used to, I think it's so much more important to look at high power in other areas of pathology. In skin, really, really try as best you can to learn to see things at low power. The vast majority of cases that I look at, I always start at 2x, go up to 4x. Most of my diagnoses are actually made there. The objective on my scope only goes up to 40x, so I never really go beyond that. You really don't need a high power cytomorphology or for much of derm path. You can get to 95% of things at a high or mid power. Terms and conditions is next. So I'm just going to run through a few, basic terms that you'll encounter, what conditions you might see them in before you kind of have your lectures on the different inflammatory reaction patterns. So acantholysis is a loss of cell-to-cell adhesions. So you see this kind of ballooning of the cells as they lose those desmosomes, those connections from each other. And the condition we see that in this image is pemphigus vulgaris. The term here is acantholytic dyskeratosis. What that refers to is acantholysis, which we just discussed, plus dyskeratosis with core rons and grains. So dyskeratosis is abnormal individual cell keratinization. And in this case, acantholytic dyskeratosis specifically means this particular exact pattern where we develop corons and grains along with acantholysis. The corons are rounded nuclei with a halo of pale pink dyskeratotic cytoplasm. The grain is kind of like, I think of it as a smushed raisin. It's a dark blue flattened nucleus surrounded by minimal cytoplasm. The condition that we see that here is Darrier disease, but there's a differential for that. So I know, I don't know if some of you might be old enough to remember the old iPhone commercials where they'd say, there's an app for that. So I love differentials in DermPath. I'm always saying, wait a second, here's a clue, or here's a reaction pattern. I know a differential for that. Let me pull up my differential so I can start running through, what this entity could be because I found a reaction pattern or a clue. And so I call this, there's a DDX for that. And so the DDX for acantholytic dyskeratosis is a trio, really. It's Grover's disease, Darrier's disease, and warty dyskeratoma. And then I add Haley slight. It's not one of the big three, but you can sometimes see a little bit of acantholytic dyskeratosis in there. Our next term is acanthosis. This is an increase in the thickness of the epidermis. This can in turn be regular, where those thickened reedy pegs all descend to the same level as seen here, or it can be irregular, where they're kind of, some are ending higher up and some are ending lower down. When you see regular acanthosis, like you see here, you should think of an entity like psoriasis. Civet bodies or colloid bodies are another important term. These are pink globular remnants of keratinocytes. And they're characteristically seen when there is an interface change, leading to dyskeratosis of our basal keratinocytes. Sometimes, though, they can extend all throughout the full thickness of the epidermis. In this case, these are civet bodies in lichen planus. A cornoid lamella. So this is a pattern of dysmaturation of the epidermis, where we have a 45-degree angle of perikeratosis, forming a column above a focus of a diminished granular layer with underlying dyskeratotic cells. So it's a mouthful, but it is definitely a distinct pattern, and that you can recognize, one that you can recognize immediately and make the diagnosis of porokeratosis. Epidermotropism is a term that we usually like to reserve for cutaneous T-cell lymphoma. What it refers to is lymphocytes in the epidermis. So they have, there's exocytosis of the lymphocytes into the epidermis, but with a relative absence of spongiosis. So anytime we have spongiosis or fluid kind of developing in our epidermis, that, inflammatory cells will make their way into the fluid. That's not epidermotropism. That's just exocytosis into associated with spongiosis. But when you have lymphocytes making their way into the epidermis, and here they are without any surrounding or very minimal surrounding spongiosis, that is epidermotropism. And that is a great clue to mycosis fungoides, the most common form of cutaneous T-cell lymphoma. So spongiosis, of course, is our intercellular edema in the epidermis with stretching of cell-to-cell junctions. So earlier when we saw kind of the maturation of keratinocytes, we saw that they were connected by these desmosomal structures, these little kind of arms that they were linking to each other. And when you have subtle spongiosis in this case, what you can see is you actually see the stretching of the desmosomes. So spongiosis is not always in your face, vesicle formation and ton of fluid in the epidermis like you would see in an acute spongiosis. Sometimes in more chronic or subacute spongiosis, you'll just see this kind of subtle stretching of the desmosomes. And that's enough to let you know that there is some fluid buildup here. This is an example of eczematous dermatitis, our prototype of spongiotic dermatitis. Eosinophilic spongiosis refers to spongiosis, but specifically with eosinophilic exocytosis into the epidermis. So when you see spongiosis plus eosinophils, that's eosinophilic spongiosis reaction pattern. And this is seen here in incontinentia pigmenti, but there is a differential for that. So eosinophilic spongiosis, I like to think of the differential as Tapa's dip. So I run through, excuse me, I run through this when I see eosinophilic spongiosis on a biopsy. I say, okay, what could I be missing here? Could it be tinea? I'll take a close look at my cornified layer to look for organisms. Is it allergic contact dermatitis? Is it pemphigus? Could there be potentially a suprabasilar split somewhere that it could be occlusive pemphigus vegetans? Could this be an arthropod assault reaction where I'd expect a superficial and deep inflammation with eosinophils beneath that? Could this be scabies? Let me look for some mites in the cornified layer. A drug eruption, incontinentia pigmenti, which is a genodermatosis that we see this reaction pattern in, where we see, in addition to eosinophilic spongiosis, lots of dyskeratotic keratinocytes. Or could it be pemphigoid, where I would see eosinophilic spongiosis, often with a subepidermal split? But in the urticarial or early stage of bullous pemphigoid, sometimes you just see eosinophilic spongiosis. So if you're not sure what the clinical is and you're just seeing eosinophilic spongiosis, not a bad idea to actually mention the possibility of urticarial or early stage bullous pemphigoid on your differential. Papillomatosis is another term. This is hyperkeratotic and undulating appearance of the epidermis around the surrounding, above the surrounding normal skin, also known as church spiring. So this kind of nice church spiring papillomatosis seen here. This is a verrucous seborrheic keratosis. But when I see papillomatosis, I have the caves differential. Now, of course, you can see papillomatosis in lots of other conditions too, but typically that's associated with other pathology, right? So for example, you can see some papillomatosis in lichen simplex chronicus, that chronic rubbing condition that we described earlier, but that's going to have other pathology as well, right? That's going to have that thickened compact corneum with a lucidum that doesn't belong on non-acral skin. Lots of other papillomatosis conditions will have other primary pathology, but if you just see papillomatosis with really nothing else on the slide, think of these four entities, caves. So carp, confluent and reticulated papillomatosis, acanthosis nigricans, a verruca, or a seborrheic keratosis. Pagetoid scatter is my next term for you. That is a buckshot scatter of atypical cells within the epidermis. So cells just kind of flying up in a disorderly array in the epidermis. This is the prototypic pagetoid scatter of Paget's disease. There is, of course, a differential for that as well. So when we see pagetoid scatter of cells in the epidermis, I think of the buckshot 7 seen here. Paget's disease, Bowen's disease can be pagetoid. Melanoma, specifically superficial spreading melanoma, has a very pagetoid appearance. Porocarcinoma and its benign equivalent hydroacanthoma simplex. Sebaceous carcinoma can have an intraepidermal pagetoid component. Merkel cell carcinoma, same, can be pagetoid in the intraepidermal area above the kind of more dermal Merkel cell carcinoma. And pagetoid reticulosis, a form of T-cell lymphoma of the skin that presents with pagetoid atypical lymphocytes in the epidermis. Okay, our boxcar or square punch. So next I wanted to kind of just run through some differentials. So we're done with terms and conditions. We're just going to do some differentials that I didn't want to leave out for you before I leave you for the rest of the series, because I won't be coming back until it's time to do neoplasms of the adnexal structures, which is one of my favorite topics, adnexal neoplasms. But until then, I want to leave you with just a few differentials that I love. So there is boxcar square punch. So this are some entities where you can see, instead of a normal tapering of your punch, you get this kind of bulky squared off form. And so we talked earlier about special site changes of a normal back. So normal back is on our square punch differential, but these other entities as well. Invisible differential. So invisible differential means you put the slide down and on low power, you're like, this is normal skin. They biopsied normal skin. And so the pathology is invisible, at least at first glance. So my invisible differential mnemonic is VITAMS U, like vitamin U. And my little joke for this is, you know, you're supposed to say, well, there is no vitamin U. And the answer is, yes, there is. It's invisible. So this, I don't actually memorize most of my differentials. I have them written down. I have them in like a, drive that I look through and access readily all the time. But this differential I know because I run through it all the time. I see, oh, normal skin biopsy. Let me start running through my invisible stuff. Could this be vitiligo, ichthyosis, tinea, argyria, macular amyloid, sclerodema, or urticaria pigmentosa, TMAP? So I'll run through this quite a lot. And of course, then you start zooming in to look for those subtle pathologic changes of all those entities. Newts in the horn differential is another really important one that I run through every day in my mind. I know this by heart, inside and out. So PP-ticks, I learned it as P-ticks, but I've since added pleva to the P-ticks that I originally learned because pleva characteristically has newts in the horn as well as a really helpful clue. So I run through this all the time: psoriasis, pleva, tinea, impetigo, candida, syphilis, sebderm. So as I'm doing my top-down approach and I'm looking at my cornified layer and I see some newts in there, I say, okay, wait, let me look for other findings of some of these entities. Let me make sure I'm not missing, a fungal infection. Let me make sure I'm not missing a subtle presentation of psoriasis. For example, a few neutrophils sitting on top of a little mound of parakeratosis focally in the epidermis can be your only clue to a super subtle presentation of guttate psoriasis. So don't miss these subtle clues and these important differentials. Busy dermis. So this is an Elstonian differential. Busy dermis killed grandma's sweet niece. I believe he came up with that. It's in his book. And then I add with leukemia and breast cancer because those are other entities that can also have kind of this busy dermis look. Now, what is busy dermis? So busy dermis is not just there's action in the dermis. No, busy dermis is a very specific reaction pattern where we see within somewhat thickened collagen of the dermis, just too many cells, right? Normally our dermis has, a few scattered fibroblasts and dendritic cells, but here we just have too much cellularity scattered within a thickened collagen. And I'll show you in a moment, kind of a scanning power of what I mean by that. But these are the entities seen here on the busy dermis differential. And this is what they look like at scanning magnification. So hopefully you can appreciate what is meant by busy dermis. Our dermis, all of our vessels and structures are where they should be. Nothing is displaced. There's not a huge goomba or a nodule of any sort in the dermis, but instead our dermis just looks too busy. Our collagen's a little bit thickened and we have just too many cells in there for one reason or another. Pegs of parakeratosis is just another cute one that I like. So this is where you see mounds of parakeratosis. Think pegs: pityriasis rosea, erythema annulare centrifugum, guttate psoriasis, and small plaque psoriasis. And then I believe this is our last one that I'm going to leave you with: superficial and deep differential diagnosis. This is really a commonly used one. So when you see a superficial and deep dermal lymphoid infiltrate at scanning power, immediately just start running through your mind the 8 L's. So to make it nice and convenient, we've made everything start with an L for this differential: light being polymorphous light eruption, lupus, lichen striatus, lymphoma and lymphomatoid papulosis, lepidoptera, which is a fancy L way of saying arthropod, Lewy, which is a fancy L way of saying syphilis, leishmaniasis, and lipoidica, aka necrobiosis lipoidica. So that pretty much brings us to a conclusion here. We've talked about the normal histology of hair, skin, and nails, an basic approach to the derm path slide, understanding some important terms and conditions, and looking at some differentials. So with that, I will turn my video back on, and I'd be happy to take any questions at this time.
Thank you so much, Dr. Skupsky. This was an amazing talk on histology, as well as so many different reaction patterns and differential diagnosis, and especially the mnemonics. I'm sure that all the busy and invisible ones will be very helpful for the trainees as well as practicing pathologists. I saw a few questions online. One question is it possible to misinterpret a telogen follicle with scarring alopecia?
Is it possible to misinterpret a telogen follicle with scarring alopecia? So I'm not sure I necessarily understand the full question, only because in scarring alopecia, as with other alopecias, you will take a look at your hair cycle. In all forms of alopecia, you'll see hairs in various levels of the various stages of the fall of the cycle. So you're going to see anagen, catagen, telogen hairs. Typically, you're going to have your catagen telogen shift, meaning a marked increase in catagen telogen hairs occurring in your non-inflammatory non-scarring alopecias. So, for example, your alopecia areata has a really prominent telogen catagen shift, almost like 50%. Whereas in your scarring alopecias, your catagen telogen shifts are usually not going to be that high. You're not going to have that much of a catagen telogen alteration of your cycle. But you'll still have some catagen and telogen hairs, and in some forms of scarring alopecia, like eventually, tricotyl and traction become scarring over time. So it's kind of an overlap area. And those you certainly do see telogen and catagen hairs. So I hope that answers that question, but let me know if it needs clarification.
Yeah, I'm asking that if there is any more clarification needed on that question, so please post it on Facebook chat window. There is another question about lymphocytes. So do we see epidermal lymphocytes in normal skin?
Yeah, so we don't see epidermal lymphocytes in normal skin per se, right? So if you have a biopsy of just normal, non-inflamed, non-pathologic skin, you really shouldn't have lymphocytes in your epidermis. You do have antigen presenting cells in your epidermis, right? We talked about those Langerhans cells that were scattered in our epidermis, but in normal, the way our body is supposed to operate, those antigen presenting cells will make their way down into the dermis. Well, they will meet the lymphocytes that are kind of making their way through the superficial dermis to encounter antigens. They'll present their antigens. The lymphocytes will make their way back to the lymph nodes and so on. So really, you should not have lymphocytes making their way out into the epidermis in non-pathologic states. However, a lymphocyte in the epidermis does not necessarily mean lymphoma. So it does not mean CTCL, mycosis fungoides. You can definitely have lymphocytes in the epidermis in non-lymphoma pathologic states. Spongiotic dermatitis will always have some lymphocytes. But again, the main way to kind of know, am I dealing with lymphoma here, epidermotropism versus just exocytosis of lymphocytes in spongiosis is there significant spongiosis there, right? So I like to think of the inflammatory cells as kind of opportunists as making their way into the epidermis. So if you have a spongiotic primary inflammatory process that's making room for things to enter the epidermis, our inflammatory cells will just kind of make their way in there. And that's a secondary thing, right? As opposed to MF, where the primary pathology is actually those abnormal cells making their way, the abnormal lymphocytes making their way into the epidermis. So I hope that helps.
Thank you. So there's another question about how to differentiate verruca vulgaris and papilloma. So maybe like it is for another lecture, but still,
Yeah.
if you want to take it.
So you will definitely have, a lecture on kind of normal or epidermal neoplasms, and I think that'll probably be covered there, as well as infectious lectures. So verruca kind of overlaps with infection. But was the question just normal papillomatosis versus verruca? So in a verruca, sometimes, first of all, it's hard, right? So verruca was on the differential of papillomatosis, and you always consider it there. Sometimes a very late stage verruca might not have your characteristic findings of a verruca, which are coilocytes, right? So coilocytic change of the granular layer, which is vacuolization of those granular cells due to viral cytopathic change. If you see coilocytes, clearly in the context of papillomatosis, you've got your diagnosis of a verruca, but we're not always lucky enough to have them there. Another clue that I like to think about for verruca compared to just plain old papillomatosis is that verruca really likes to have kind of a cup-shaped appearance, or also known as towing in of the reedy at the edges. So our acanthotic epidermal reedy at the edges of the verruca like to kind of toe in at the edges, and that's really characteristic architectural features of verruca.
Right. There is another question, Dr. Skupsky. Maybe you covered it before that. Do you have any suggestions of dermatopathology resources for medical students?
Resources for for
Dermatopathology research, I think study research, that's what they mean.
Yes, absolutely. I mentioned at the beginning of the lecture, Dirk Elston and Tammy Farringer book is my absolute favorite as a primer. So read that cover to cover. It's not hard to do. It is very succinct. That's my favorite place to start. Beyond that, there's another great book written by Ron Barr and Christine Coe that's called Dermatopathology Diagnosis by First Impression. And this is a really kind of fun book that is an exercise in dermatopathology that looks at different entities, comparing them side by side, things that look similar at low power. So I already told you how important low power diagnosis is in dermpath. This is a book that is all about that. So it takes things on low power. It says things like, lots of, vessels on low power. And, and then it shows you things side by side that show that pattern. And so that's a really great book to kind of work through, and it'll make you an absolute superstar in terms of low power diagnosis.
So it's the book by Diagnosis by First Impression. Is that correct?
That's right. And that's the author is Ron Barr, who is a mentor of mine at UCI, and Christine Coe, who is at
Yeah,
Yale.
I'm putting it in the chat box so that they can see it.
Wonderful.
Okay. And in fact, actually, Christine Coe will be delivering the next
Yes,
lecture for us.
she will. She'll be one of our star-studded lineup.
Yeah, exactly. So hope to see all of you at that time. So there is another question, Dr. Skupsky, about the thickness of skin layers. So, I mean, the thickness of skin layers in different areas of the body and how they influence different skin pathology.
Yeah, so we kind of looked at the different skin layers when we looked at the side by side from the different anatomy areas. So we really see that in the skin, form meets function. So it will relate to pathology in the sense that certain skin pathology only presents at certain sites, right? So for example, if you're getting a biopsy of sclerodema, which is increased mucin in the deep reticular dermis, that better be happening from the back, typically of a diabetic patient. If you're getting a biopsy, of lichen sclerosis atrophic, that commonly happens on the genital skin, although it can happen in other areas as well. So it's helpful to kind of know the different, areas where the skin is different, and recognizing, where is this biopsy coming from based on how thick is my epidermis, how thick is my dermis, are the collagen fibers thick like on the back, or are they thin and delicate like in mucosa or area or genital skin? Is there solar elastosis kind of replacing my superficial dermis? Then, that's pathology in and of itself that lets you know that you have UV damage. Be on the lookout for neoplasms related to UV, et cetera. I hope that answers that question. But it's just important on so many levels to know kind of where the skin that you're looking at is from, and if it looks, specific things that you might encounter in that location.
Right. No, maybe there was another question, like suppose somebody about the thickness. So somebody is looking at thick skin, for example, sole or palm versus like, the other parts of the body. So does it like influence your approach to the skin biopsy?
Oh, to actually performing the biopsy?
No, in interpreting.
So it doesn't change my approach at all. I'll still do my top-down approach and I'll still look for my inflammatory patterns and clues. But what it does do is as I'm doing that approach, right? So if I were to do my top-down approach for each of these, right? I put my slide down and the first thing that I see is this. I say, okay, top down, I see really marked hyperkeratosis and stratum lucidum. I must be on acral skin. And now I'm already starting to think of, in my mind, I put my dermatologist hat on and I say, okay, I'm starting to think of things that could be happening on the palms or soles, right? And everything in DermPath you'll learn has special site features as well. So for example, as we look at melanocytic neoplasms, it makes a big difference where you are. So if I'm, on the palm or sole and they're biopsying rule out a pigmented lesion, I'm going to have a very different kind of set of parameters where I'm going to be looking at the melanocytic architecture and cytomorphology in special sites like acral nevi and acral melanoma versus, other skin sites. So immediately kind of recognizing where you are and kind of shifting your brain to kind of, okay, where, which direction am I going to go, whether it's inflammatory or neoplastic, but keep doing that top-down approach. Doing so, looking at each and every layer will help you identify where on the body you are. And again, I think that's a fun exercise, and I think it's a useful exercise to do blinded when you're looking at a slide.
Right, no, thanks. There is one more question. On CIVATI bodies that you mentioned about dead keratinocytes, are they specific to lichen planus, or you can see them in any other conditions?
Excellent question. So oftentimes when we say CIVAT bodies, that specific term tends to be reserved for lichen planus. However, the same exact thing, the same exact process, which is basically a dead red keratinocyte, happens in pretty much all versions of interface dermatitis. So you'll learn with Dr. Junkins Hopkins about the interface inflammatory reaction patterns in our upcoming series. But in all of those, a characteristic finding of interface is some dyskeratotic dead red keratinocytes, sometimes just kind of at the junction and sometimes scattered higher up. And you're not wrong if you call them CIVAT bodies. It's just that that particular term is characteristically used for lichen planus. So when they're in other entities, I sometimes will call them just dyskeratotic keratinocytes. Sometimes I call them cytoid bodies. So you really, you're not wrong. It's really the same thing. Yeah.
This last one question for you from one of our colleagues that I have a really great difficulty in identifying mild acanthosis. Any tips? I think that is interesting. This can happen to anyone.
Yes. No, I think that's very relatable. I do too. I find that sometimes when I'm looking at slides, I'll say, okay, I think there's a little bit of acanthosis here, but it's hard to necessarily know if it might be site related, especially when I'm looking at a slide blinded, right? There are some areas where our epidermis is expected to be a little bit thicker than others. Once you kind of know where on the body you've come from, you'll kind of be able to say, oh, and once you've seen a gazillion slides, that's where the experience kind of takes over. When you say, okay, now I see this is from the face, and it's this thick compared to, all the other skin that I normally see on the face. This is acanthotic, but it really is a very relative thing. It's relative to where you are on the body. It's relative to the stage in the process too. So inflammatory dermatopathology is not a static thing. Another kind of Bernie acronym is the so-called the lives of lesions. So, no inflammatory state is going to have just one look to it. You're going to have kind of a transition, spongiatic dermatitis, for example, in some stages can be very acanthotic in the chronic stage, right? It can be psoriasiform spongiatic in the chronic stage, or it can be just mildly acanthotic or not at all acanthotic in the very acute phase. So you're not alone in having a hard time defining acanthosis very precisely.
Right, no, thank you so much. Going back to your answer on CIVAT bodies. So I practice GI pathology, but sometimes in esophageal biopsies, we get a lichenoid inflammation. So and then I think the only thing that the way to differentiate between just lymphocytic esophagitis, which can be more non-specific from lichenoid inflammation. So we do look for CIVAT bodies, and actually recently we had a case in which the patient had a history of cutaneous and mucocutaneous lichen planus, and the esophageal biopsy was showing a lot of CIVAT bodies and lichenoid inflammatory pattern. So my question is I think that what is your experience as a dermatopathologist about mucocutaneous or esophageal involvement by lichen planus? Unrelated question a little bit. Sorry.
So what's my opinion on involvement there?
Yeah. Yeah, or experience. Have you seen some
Yeah,
cases?
so I don't get too many oral pathology biopsies. Because I'm a dermatopathologist, I'll get a few at the VA setting that I work at, where, the other pathologists will share their cases with me. But because I work mostly in, practices where just dermatology clinics are sending, I don't see too much of it myself. But in the cases that I have seen, yeah, it's very, very similar, other than, of course, the changes that we talked about being the epithelium is different, right? Non-keratinizing, glycogenated epithelium. But otherwise, the interface process is quite the same. You have that obliteration of the dermal epidermal junction. So you no longer have a nice crisp, delineation between your epithelium and your, in this case, submucosa, in my case, epidermis and dermis. Epithelium and lamina propria. And so that obliteration of the junction with lymphocytes and lots of those dyskeratotic civat bodies is a really, helpful finding. In DermPath, we also have the helpful finding for lichen planus of hypergranulosis. So you get this characteristic beaded hypergranulosis, which I imagine on mucosal surfaces you're not going to get because you don't have a granular layer.
Right. That's true. No, I mean, that's great. Thank you again, Dr. Skupsky, for this excellent lecture. And you would be happy to hear that we have a couple of hundred viewers from all over the world, and they are very thankful and with a lot of compliments coming on that this is a nice anatomic presentation of the skin and a nice review and a lot of compliments. And our viewers range from all over the world, including places like Uzbekistan, Saudi Arabia, Colombia, Brazil, Ecuador, Sudan, Zambia, Pakistan, Cambodia, India, Turkey, and many joined from the United States as well. And thanks to all our viewers for your support to Padcast. And as we continue to offer lectures on different pathology topics by eminent speakers, and please follow Padcast on different social media platforms on Facebook, YouTube, Instagram, as well as on X. And you can scan this barcode to get access. And as our next DermPath lecture series that is coming up on towards the end of this month. So we will have Dr. Christine Ko, as Dr. Skupsky mentions about her book, and she is going to talk about psoriasiform and spongiatic dermatitis on October 29. So hope to see you again on October 29 for our next DermPath lecture series. But our immediate next lecture is on hematopathology as we continue with our other lecture series on HemPath, and we will have with us Dr. Kamran Mirza, who is going to talk on myelodysplastic syndrome. That's on October 8th at the same time. So hope to see you all on October 8th with Dr. Kamran Mirza. And thank you again, Dr. Skupsky, for this great talk. We appreciate it a lot.
Thank you so much for tuning in, everybody. This was great. Thanks so much. Bye-bye.
Thank you. Bye.